There's a lot of thyroid disease out there, lots and lots and lots, but lots of people to help and lots of people who come in and they're like, oh my gosh, I feel completely back to normal. It's so rewarding to see that.
Dr. Brittany Henderson, welcome to eShadowing. How are you doing, my friend?
I'm good this evening. I'm ready to go.
I'm excited to hang out with you and 1,300 or so of our closest pre-med medical student friends from all around the world to talk about thyroid disorders and endocrinology and how do you get to where you are in the world of medicine. So I'm excited to chat with you and hopefully help some students get an understanding of what you as an endocrinologist, as a thyroid specialist, do day in and day out. So let's start with one of my favorite questions is how in the world do you come to decide that you love thyroids and wanting to take care of patients with thyroid disorder?
So a funny anecdote is that, going through medical school, I really liked endocrinology, and every year at Thanksgiving, I'd go around to my entire family and I'd give everybody a thyroid exam just to make sure I wasn't letting anybody go with thyroid nodules or thyroid issues.
Nice.
But I mean, going through medical school, I knew that I really liked the endocrine system. I majored in chemistry. I liked the negative feedback and like all the different loops and how it really made sense, negative feedback on the pituitary gland and everything. And I also liked geriatrics, but I realized that I liked the patient population. I liked the older people. I didn't as much care for like the incontinence and the stool impaction, like that wasn't as exciting to me as the actual endocrine stuff. So ended up actually shadowing a lot in medical school and in residency. I actually would, after call, go over and shadow with one of the endocrinologists in the community. And kind of get more exposure that way. But that's how I came to like endocrine and why I decided to go into it. And then thyroid is a subspecialty. I really enjoyed the patient population. It's mostly women. It's like 10 to 1 women to men. And also there is a lot of thyroid disease out there. So Hashimoto's disease is by far the most common autoimmune thyroid disease. I think that the current thinking is it's 1 in 8 women. Probably it's more than that, 1 in 4 or 5. And thyroid nodule is really common. Thyroid cancer is the most common and fastest growing cancer in women. So really, really a lot of patients to help.
Yeah, very interesting. It seems like next to OB, it's like up there in terms of women are your patient population. So that's kind of cool. Talk about why is that? Why is thyroid disorder so skewed towards women?
So we don't know for 100% sure, but we do think that autoimmune disease in general is more likely to impact women. Some of the triggers for that include, postpartum period. That's a really big time when we see autoimmune thyroid disease. And we think that it's because, 9 months of being pregnant, it's a like low immune state, and after gestation, after delivery, we see a lot of increase in the immune system. We see a lot of autoimmunity in the postpartum period, and autoimmune thyroid disease is one of the most common things that we do see. And I don't know. I mean, there really isn't a definitive answer for why it's more women compared to men, but it's 10 to 1 women to men. And it's very common to see it in families. So if a person has a mother or a sister or a grandmother with autoimmune thyroid disease or with thyroid issues, they're at a higher risk to get that too. And I always tell patients if their dad has autoimmune thyroid disease, they're pretty much guaranteed to get it. So I will counsel my patients if there are other females in the family when they hit 10 years old to start screening their kids for autoimmune thyroid disease.
Wow. Well, my wife won the autoimmune lottery, has multiple autoimmune disorders, including Hashi's. So she's one of the lucky ones. Talk about the training path. One of the most common questions is what is the length of training to become a thyroid specialist or an endocrinologist in your case?
So 4 years of medical school, and then 3 years of internal medicine residency. And then usually a normal endocrine fellowship is 2 years. I did a 3-year fellowship at Duke. The third year was on a T32 training fellowship. So I was in the basic science lab, doing animal research, doing research in cells. So I did a 3-year fellowship. And then after that, I joined faculty and it started running the thyroid program.
Yeah, very cool. One of the common questions I like to ask is bread and butter. I think a lot of students have this fantasy that something like emergency wounds, it's all stab wounds and gunshots, and they don't think about all of the boring stuff that's kind of day in and day out. For you as a thyroid specialist, what are the bread and butter that you're seeing day in and day out?
So definitely Hashimoto's disease. It is an autoimmune disease where the immune system attacks the thyroid as not part of the person. And you get positive antibodies, TPO antibodies, thyroid globulin antibodies, thyroid stimulating immunoglobulin, TRAbs. It's kind of fun because you see this huge spectrum of autoimmune disease, which can manifest as both hypo and hyperthyroid symptoms. That is by far the most common. People on thyroid replacement medicine, which is an art in and of itself. I mean, there's science to it, but it is an art. I'll tell you that much. And then thyroid nodules, really, really common. I tell people that having a thyroid nodule is about the same percentage as their age. So 20% of 20-year-olds, 30% of 30-year-olds, 40% of 40-year-olds, and so on. 95 to 99% of the time, they're benign.
What is a nodule?
A nodule is one of two things. It's either extra cells within the thyroid itself, and most of the time those cells are benign. They're just extra thyroid follicular cells, so they look a certain way on ultrasound. And also, you can have a thyroid nodule that's cystic, so full of fluid. So you can have a big cyst. I've drained about 90 cc's out of somebody's neck once, and I have lots of people with humongous cysts that obstruct their airflow, that make it really difficult for them to swallow. And so we see that a lot. And like I said, most of the time they are benign growths. People have those because of Hashimoto's as an underlying cause. Iodine deficiency can cause that as well. Iron deficiency, anemia can cause that. And then we also think that exposure to different chemicals in the environment, so chemicals that are endocrine disruptors, like flame retardants in your electronic equipment or in your couches or in your mattresses, all of those things that we're exposed to on a daily basis can disrupt thyroid hormone too. Yeah.
Very interesting. I had a great question that just went away from me. Oh, talk about you talked about extracting or removing 90 cc's of fluid from a patient. It sounds like, especially with some extra training that you had doing ultrasound, neck ultrasound, that you as a thyroid disorder specialist can have the opportunity to do a lot of procedures.
We do procedures all the time. So every single week we're doing procedures. Draining cysts. We do something called alcohol ablation therapy, which is where we drain fluid from the cyst. And usually cysts look either like urine or beer that you're draining from somebody's neck, or they can look like motor oil, like really, really dark, thick fluid. The other week I drained something from somebody. It took forever to drain this thing, but it was disgusting. It was like thick boogers everywhere. I mean, that's all I can compare it to, but that is what came out of her cyst.
It's like a pimple popper type.
Oh, disgusting. Yeah. But with those cysts, because they're so big and they have a really thick cyst lining, we can inject them with ethanol, like pure alcohol. And the alcohol can actually kill off the blood supply to the cyst wall so that the cyst wall can then collapse and that you can get rid of the cyst and it can stop accumulating. So we do that a lot. We do FNA biopsies, and we look under the microscope, like bedside, to see what's going on and kind of decide what we need to do. We do molecular testing where we can look at all of the known cancer gene mutations for thyroid cancer, thyroid gene fusions, and figure out if the nodule needs to come out or if we can just watch it. But it's fun. It's a lot of procedure too.
Wow. So FNA biopsy, just for the students, so that's a fine needle aspiration biopsy. So it's a nice little needle, stick it in and pull some stuff out.
Yes.
Very cool. I want to jump into cases because students love cases, and I know you came prepared with some, so thank you for that. And then we'll see if we have some time for Q&A at the end. And the students, keep your questions coming. I see them on the side, and I'll ask them as they come in.
Okay. So just one question. What time do we have until?
Until 9 your time.
Okay.
An hour.
So I'm going to start this, and this is like a really cool case. So definitely not your bread and butter kind of thyroid disease, but we'll go through one of the coolest cases I've ever seen here. So this is a 71-year-old white female. She presented with a history of right TMJ discomfort for 2 years. She was relatively healthy and had a past medical history significant for a distant history of breast cancer and hypertension. She underwent chemo in the past and radiation 25 years ago. No history of active or passive tobacco use. Vital signs showed a blood pressure of 146/74, heart rate of 80, a respiratory rate of 12, SpO2 of 100%, normal temp, and 120 pounds with a height of 5'2". On physical exam, she was a well-nourished female with a palpable right jaw mass and pain on palpation. She had no palpable thyroid nodules. She had no goiter. Her cardiac, pulmonary, abdominal, joint, neurological examinations were all within normal limits.
It's Hashi's. It's got to be Hashi's, right? It's coming.
We'll see. So imaging studies showed a 4.1 centimeter mass that had destroyed the right mandibular condyle.
Ouch.
It infiltrated the parotid and masticator space, and it involved the right tempomandibular joint. And so she came to me, and I'm like, what? Like, what the what? An FNA biopsy was done, and it showed a well-differentiated follicular thyroid carcinoma, or follicular adenoma. They wouldn't have called it carcinoma on FNA. And ultrasound demonstrated no suspicious intrathyroidal lesion or lymphadenopathy. So I did her thyroid ultrasound. I didn't see anything that would have contributed to this huge jaw mass. She had like a little tiny cyst, but nothing else. I actually ended up biopsying the cyst within her thyroid just to be 100% certain that was all benign. But this is a little weird. So upon further medical history taking and probing, sometimes you have to probe. Sometimes you have to ask more questions because this doesn't make very much sense. The patient revealed that she forgot to mention she had a past medical history of a pelvic dermoid tumor that was removed 48 years ago without reported malignancy. So what is a dermoid tumor? So an ovarian germ cell tumor is derived from germ cells of the ovary. They may be benign or malignant and primarily arise in young women between the ages of 10 to 30 years old. There are about 70% of the ovarian neoplasms in this age group. And there are several different types, but they're embryo-like neoplasms that differentiate primarily towards extra-embryonic, fetal-derived cell populations or a mixture of both. And teratomas are one. That's the most common. You can have something called a dysgerminoma, which is immature germ cells. You can have a yolk sac tumor, and these are usually more malignant. Mixed cell tumor, which is a mix of all of the above. And then you can have some more rare kinds of tumors that I've never seen in real life, but they're worth mentioning.
So teratomas, most people would understand. You have a good picture here of one. With the kind of advent of Instagram and all the accounts that show cool cases, teratomas are the ones that have the mass with like teeth and hair and other weird stuff in it.
Yeah, disgusting. So on your left there is a hairball. Ugh. And you can see teeth in these. You can see like sebaceous cysts. You can see muscle, urine, lung, GI tissue. Crazy. And you can see thyroid, interestingly enough. And the mechanism by which these cysts develop, we're going to talk about this in a little bit more detail, but it's failure of meiosis 2. And also potentially meiosis 1. We'll talk about that. And they're bilateral in about 10 to 17% of the cases. This is a multicystic mass containing hair, teeth, skin, all of that stuff, and foul smelling material. So there you go.
Wow.
Fun times.
Yeah.
So monodermal, highly specialized teratomas are rare. This is a subset of teratomas that have a predominant histologic cell type. The most common is something called struma ovariae. Carcinoid is also a common type, which is a well-differentiated neuroendocrine neoplasm. Both of these things are endocrine. So endocrine is cooler than you would have thought. And they are unilateral, although a contralateral teratoma may be present. So struma ovariae is mature thyroid tissue. And you can actually get secretion of thyroid hormone from these ovarian neoplasms in about 25 to 35% of patients. I'm actually working up a patient right now for this who is super hyperthyroid, and she doesn't have a thyroid gland at all. She's had radioactive iodine ×2 and surgery ×2.
Wow.
Off thyroid medicine, still hyperthyroid, and we think she has functioning thyroid tissue in her abdomen. But this is about 2.7% of ovarian teratomas, and most of the time they're benign. Malignancy is seen when these things actually metastasize to other regions, and we'll talk about that here. So here's the case again. So she had this jaw tumor, as you can see here on the bottom. And we did an iodine 123 whole body scan, which showed multifocal metastatic struma ovariae involving the right face, the right jaw, multiple osseous structures like the spine and the ribs, the porta hepatis, and then she had this intraatrial uptake within the septum of the heart.
Wow. Talk about the iodine 123. What's so special about that with thyroid tissue?
So a lot of times you'll hear about iodine 131 when we use that for radioactive iodine in Graves' disease, for example. Iodine 123 is just a radiotracer that's used for uptake before iodine 131 is given. We used to give iodine 131 to do the imaging studies and just the scans, but because it is like destructive radioactive material, we thought that giving low doses of iodine 131 before treatment doses of iodine 131 can actually cause stunning of thyroid cancer tissue or thyroid tissue and make it less effective. So iodine 123 just is a better radiotracer. It doesn't cause destructive thyroiditis. It doesn't cause, nuclear radiation to the thyroid tissue. Is just a good scanning material.
Let me clarify just a little bit. I think it'll be good for the students. The iodine in general, why is that so special for the thyroid? Why does the thyroid like the iodine?
So iodine is the most important primary material for thyroid tissue and for making of T4 and T3. So iodine is taken up out of the bloodstream. It is bound to something called thyroglobulin, and then T4 and T3, thyroxine and triiodothyronine, are made from that starting material, shuttled back through the thyroid follicular cell and then into the bloodstream again. So iodine is really, really important in the making of thyroid hormone.
Yep. And things like goiters, a lack of iodine, and why we add iodine to things like table salt.
Totally. Yeah. Back in the 1900s, if you look at American history and American art, everybody in American art had goiter. Even the dogs on the street had a goiter. I think in World War I, up in Michigan, with the people who were actually enlisting in the army, about 30% of them got thrown out because they had a goiter.
Wow.
So when they introduced iodine into table salt, that is what helped to decrease the incidence of hypothyroidism, to decrease the incidence of goiter. And now in the American diet, we have too much iodine everywhere. But unless you're vegetarian or vegan, then you're probably not getting enough.
Very cool. All right. Thank you for that.
Yeah. Okay, so here is the cardiac tumor. We took that sucker out. It demonstrated a 2.3 centimeter well-circumscribed mass in the right atrium attached to the intraatrial septum near the tricuspid annulus, and it was removed surgically. On pathology, it appeared to be bland follicular thyroid tissue. It didn't look cancerous at all. And this is what it looked like. So if you look up, what does thyroid tissue look like under the microscope, this is it. So everything in light pink is your colloid. Colloid is what houses thyroid globulin, which is the precursor to T4, T3. And then around the colloid are thyroid follicular cells in these follicles. So in these little tiny circles and all of different sizes. This is benign looking thyroid tissue.
And just to clarify, you said we took this sucker out. It wasn't you that was going in performing heart surgery.
No, you don't want me to do surgery. No. Cardiothoracic surgery did this for us. Yeah. So this is something referred to as Stromocortis. Cardiac ectopic thyroid tissue. It's a rare condition. It affects 1 in every 100 to 300,000 people, mostly middle-aged women. And most of the time, this is just ectopic that has been within the heart since, gestation. And the way that works is the thyroid primordium starts between day 24 and 32 of pregnancy. It's a thickened endodermal epithelium located at the base of the embryonic midline, and the base of the tongue forms and is commonly referred to as a foramen or blind orifice. And the appearance of this ectopic tissue is the result of aberrant embryogenesis during migration of the thyroid during the 4th week of pregnancy. And you can see this thyroid tissue actually wind up within the heart. Usually when it's ectopic from embryogenesis, it's in the septum, in the intraventricular septum, or in the right ventricle. And the metastatic disease to the heart from disseminated struma ovariae is pretty much unheard of. So this one was actually in the atria, which is kind of crazy.
Wow.
So a total thyroidectomy was performed. Histology was negative for thyroid malignancy, so it doesn't look like it came from the thyroid. And postoperatively, we did give the patient something, radioactive iodine, 150 millicuries, to treat the metastatic struma. We also gave her high-dose prednisone to decrease intratumoral swelling because of the tumor in her right jaw. And after treatment, her right facial pain and swelling slowly resolved. A whole body scan with iodine-131 performed 9 months later showed minimal residual uptake in the mandibular tumor and a 60% decrease in mandibular tumor volume. So here the plot thickens.
Dun, dun, dun.
Dun, dun, dun. So interestingly, the patient's husband was an MD, PhD geneticist and the medical director of a large genetics research clinic in South Carolina. So he and I said, well, we might as well study your wife now that she presented like this, because that's really strange to have a metastatic struma ovariae to the jaw and to the heart. And so we took her peripheral blood and we took her normal thyroid, we took her mandibular jaw tumor and cardiac tumor, and we started doing a molecular analysis. And we also looked at 2 additional cases of what we called extra-ovarian struma ovariae, taken from Indiana University and Duke, and then 7 cases of intra-ovarian struma ovariae, so struma ovariae that did not travel outside the ovary, and then started doing microarray analysis, whole exome sequencing, and RNA-seq to see what the heck was this all about, just to kind of prove our point of what happened here. So this is an example of normal heterozygosity of the genome with a copy number of 2 in the peripheral blood. So if you can look on the bottom, you're going to see, you have in the middle AB, on the top BB, on the bottom AA. So you have 1 copy from your mom and 1 copy from your dad. And this is what is, normal. If you look on the bottom, here are all the different genes. So gene 1, 2, 3, 4, 5, 6, all the way up to like X and Y. And you can see that every single gene in her bloodstream was heterozygous. That's normal.
Let me ask a quick question that came in from a couple of slides ago. The fact that you did a total thyroidectomy, knowing that there was this tumor that the patient had, why remove the patient's quote unquote normal tumor? Or not normal tumor, normal thyroid?
So that's a good question. Because we wanted to use the Iodine 131 as treatment of her metastatic disease, her jaw tumor, her bony tumors, we had to remove the actual normal thyroid because the normal thyroid picks up Iodine 131 about 1,000 times better than tumor tissue. So if we had given her radioactive iodine, it would have just killed her normal thyroid tissue and not actually gotten into tumor cells. So you remove the normal thyroid, and then when you give the treatment dose, it actually gets to where it's supposed to get to.
Yeah. So to kind of clarify again, because the students may not understand that, right? What I think is like, why remove it if you're going to kill it anyway? But it's because it's going to take all of the medication that the 131 that you're using to try to kill the tumor, and you want that 131 to go to the tumor and not to the healthy tissue. So you just take the healthy tissue out, even though it's going to die anyway.
That's right.
To treat the tumor. Interesting. Yes. Very cool. Yeah. Okay.
So here is an example of heterozygosity. So you inherit both genes from one of your biological parents, and then you get different genes, like so you have the homozygous BB, the homozygous little BB, and then 50% of the time you're having like a more of a heterozygous kind of picture here. So this is normal, and this is what we mean by heterozygosity. Homozygosity, we mean the same, capital B and capital B, little b and little b, derived from the same parent. And I'll show you that here down the road too. So when we looked at her actual cardiac tumor, we have the same copy number of 2, so derived from, theoretically 2 parents. But interestingly, along the entire genome, she had something called whole genome homozygosity. So nothing here in the middle. It was either big B, or little b, or big B, little a. So everything was homozygous. Nothing was heterozygous. What the heck? That's a little weird. And that was her bloodstream too. So completely different. And then when we looked at her mandibular tumor, which was more aggressive. So the cardiac tumor was just hanging out in the atrium. Her mandibular tumor was actually infiltrating and aggressively destroying bony tissue. We saw the same thing, whole genome homozygosity, but in chromosome 7 here, right here, we saw the loss of a portion of chromosome 7, one of the P arms, and we call this the second hit. So our working hypothesis at this point was that, you had to have some kind of a second hit, which maybe made the tumor a little more aggressive, that might, cause it to infiltrate and destroy bony tissue as opposed to just hanging out somewhere. These are some additional cases. So these were cases from Duke University and Indiana University. This is one of the cases which had a struma ovary that had metastasized to a periaortic lymph node. It had behaved indolently, so it wasn't, infiltrating bone. It wasn't causing other issues. It was just hanging out in a lymph node. And as you can see in this one, there were areas of homozygosity within each gene, but also, heterozygosity as well. So we called this segmental whole genome homozygosity. It wasn't the entire genome. It was a little different. Same thing with the other case that we looked at, which was an intra-abdominal tumor that was a little more aggressive. And in this situation, we saw segmental whole genome homozygosity again, but mosaic gains in both chromosomes 3, 20, and X, as you can see here. And so gain of function here. So that's, again, maybe another second hit, which might make these tumors a little more aggressive.
Can you just clarify second hit? What does that mean again?
So the first hit would be the fact that it failed meiosis 1 or 2, and we're going to talk about that. And it became a tumor where it is homozygous instead of heterozygous. And then the first hit, That's the first hit. The second hit is either loss of one of the chromosomal arms or gains in function in some of the chromosomes, where you can see this at chromosome 3, 20, and X, that the actual copy number is raised. And that is called a mosaic gain. So that can make, again, the tumor a little more aggressive because it has 2 genetic hits.
Okay.
And then these are intra-ovarian struma ovary cases. So we looked at 7 of them, and all of these cases stayed within the ovary. So you know how I showed you the teratoma with the big wad of hair? Well, these were all cystic, like ovaries with just mostly thyroid tissue within them. And what they showed was that there were no second hits, so nothing aggressive. And again, they showed segmental, homozygosity. So most of the time, these were heterozygous tumors, but they did have some segmental homozygosity. There was one tumor over here on the right side that showed that all of chromosome 3 was homozygous, but no other tumor looked like the lady that we just saw in the case, where she had this crazy whole genome homozygosity, metastatic to heart, metastatic to jaw, like metastatic everywhere, just craziness. And so what is the proposed mechanism of action? So over on the left, you can see normal. So you have a copy from your mom, a copy from your dad, mama, papa, and then meiosis 1, where you have, what I show here in B, and crossing over. So, changing up of genetic material, and then meiosis 2, where you have what I showed you, a copy number of 2, and 50% of it heterozygous, 25% homozygous, 25% homozygous. In the middle is the actual patient that we discussed. So this is what we think happened. She got a copy from mom and dad, meiosis 1 failed, and she didn't have any crossing over. And then meiosis 2 also failed, and then tumor formation. So she had complete homozygosity. Segmental whole genome homozygosity is exactly what I just showed you, except for there was crossing over after meiosis 1 and then tumor formation, which shows, some areas of the chromosomes are homozygous, some areas of the chromosomes are heterozygous, depending on what happened with the crossing over after meiosis 1 is completed. But this is, again, failure of meiosis in tumor formation.
Wow.
And so in conclusion, using the OncoScan microarray technology, we were the first to show that intra-ovarian and extra-ovarian struma ovary are mosaic tumors that demonstrate complete whole genome homozygosity or segmental whole genome homozygosity without typical thyroid cancer gene mutations. That's a part of the study I didn't go over, but we did look for typical thyroid cancer gene mutations and gene fusions. None of them had that. And our index case demonstrated that complete whole genome homozygosity requires errors in both meiosis 1 and 2. A majority of the tumors demonstrated segmental that occurred due to sole errors in meiosis 2. And we thought that also that these tumors were predisposed to second hits, which might increase tumor aggressiveness and malignant potential.
Wow.
And so, in conclusion, our patient had a repeat Iodine 123 whole body scan a year later. She had decreased uptake to the jaw, but she had several metastatic rib and spinal lesions appear. Probably these were already there at the first time she was treated, but like I said, when you give radioactive iodine, it goes to the thyroid tissue that uptakes it most aggressively. So that's why we removed the thyroid. Probably it then went to the jaw because it's a huge tumor. Now we're able to see some metastatic rib and spinal lesions, and she was treated again with Iodine 131. And after the second treatment, her scans became negative. Her jaw tumor significantly decreased to less than 80% of her original volume. Pain resolved, thyroid globulin, which is the tumor marker that we check with thyroid cancer, came down as 0.9. Ideal is less than 2, so it was good. And she's playing tennis, living life. We did publish this, so I do have the article and I can send it to you, but this is the the article there.
Very cool. A lot of students have asked, when you remove that healthy thyroid tissue, don't they become hypothyroid? What do you do then?
Yep, they do become hypothyroid, and so they will go on thyroid replacement medicine. So typically, the American Thyroid Association will recommend T4 only, which is Synthroid or levothyroxine therapy. In my personal practice, I use that, but I also use T4 and T3 combination therapy after a total thyroidectomy. And I do that because in a normal thyroid, 80% of what the thyroid produces is T4, 20% of what the thyroid produces is T3. So if you're removing thyroid tissue, it is of best practice to give back both hormones.
Interesting. Okay.
And I said if we had time, and I don't know, we have about 20 minutes to ask me about the case of the girl who always thought that she was a frog.
I would love to hear this one.
So I'll preface this with not all thyroid patients have crazy ectopic tissue, but this is a case of a 32-year-old female who came into my office for the first time, and she was about 36 weeks pregnant, about to have her baby. And so, she came in, she had typical hypothyroidism, Hashimoto's disease, positive antibodies on thyroid replacement medicine, and came in just for like a routine thyroid, established care and kind of just make sure she's on the right road here. So in my practice, I use ultrasound a lot because I think it's really helpful for me to figure out what percentage thyroid reserve a patient has. So for people who've had Hashimoto's disease for like 25 years, when I look by ultrasound, I see like either really jacked up looking thyroid, like really hypothyroid, horrible looking thyroid tissue where the immune system attacked the thyroid gland. And because of lymphocytic infiltration, which another name for Hashimoto's disease is lymphocytic thyroiditis, by ultrasound, instead of seeing a nice, bright, white, smooth thyroid gland, you will see a very dark thyroid gland, like black as night. And you will see like lines of scar tissue and a very heterogeneous ecotexture, sometimes increased vascular. It looks horrible. But sometimes after a long time of having Hashimoto's disease, the immune system is so powerful in these people's bodies that it can kill the thyroid to the point where it shrivels up and dies. We call that atrophic thyroiditis. And it looks like these people have had thyroid surgery. That's how bad it is. So in this patient, I was doing an ultrasound and I'm like, oh, she doesn't have thyroid tissue. This is so crazy. Like she must have had this for a long time because there's nothing left in the thyroid bed. And she had positive antibodies for Hashimoto's. So then I'm like, oh, wow, you like have no tissue here. She goes, oh, you know what? Can you look at something for me? And I'm like, okay. She's like, ever since I was 5 years old, I've had this like lymph node here under my chin. And when I was 5, I thought I was a frog because I could go like this with my tongue and I'd have this thing like bouncing up and down underneath my chin. And I was like, what the heck? Like, what are you talking about? So I look and it's her thyroid, a little ball of thyroid tissue underneath her chin. So if you read about ectopic thyroid tissue, the most common form of ectopic tissue is a sublingual thyroid gland, which is at the base of the tongue. So if you stick your tongue out, you can actually see it at the back of the throat. Base of the tongue thyroid. But this is called a submental thyroid gland. So it's actually thyroid tissue that is underneath the jaw. Very, very rare. And this girl had never been diagnosed with it. She always just thought she was a frog. 32 years old, pregnant, had probably had hypothyroidism throughout most of her adult life and was really short compared to the rest of her family. So hypothyroidism in puberty or in childhood, it presents as low growth, increased weight, low growth. So she didn't actually probably attain her full growth potential, her full adult height. And just, I think, a crazy story to have never actually been diagnosed with this ectopic thyroid tissue underneath her jaw. Now, the way to actually prove that, because I didn't do a biopsy of the tissue, I just did an ultrasound, would be to either biopsy the tissue and show thyroid follicular cells, or do a thyroid uptake scan and show that it lit up underneath the jaw, like the iodine 123 that I just showed you. But she's breastfeeding, so we're not doing that yet. But that might come out in a future journal article, because it is really rare to have that.
Yeah, that's very interesting.
Mm-hmm.
If you have a few extra minutes, I'd love to bring some students on who can ask some questions.
Sure.
All right. If you want to come on, raise your hand to speak. We'll accept a couple people in here. The girl who thought she was a frog. a children's novel we got for you there. Very cool. Let's go ahead. We can turn off slides and we'll have some people in here. Very, very exciting. All right. We have Shane, who's with us every week, who gets to come ask questions. Hello, Shane.
Hi. So I can just say, I find everything we've been talking about today super fascinating. So I'm going to limit my questions. I kind of wanted to know, so you kind of showed like what the exome sequencing looked like when there was whole genome, homozygosity, and segmental. I'm kind of curious, like, could you describe what it would look like in just chromosomal abnormalities, what that would look like roughly on the data?
Oh, like repeat that again, Shane, at the very end. What it would look like? What
it would look like on that figure that you had, where all the bands would be.
If it was what?
If it was normal, healthy tissue with no chromosomal abnormalities like that.
So, I mean, I showed you on the peripheral blood. So it was a copy number of 2. You had about 50% of the thing right in the middle. So you're going to have like big B, little b, and then 25% high, 25% low. All chromosomes should look that way. And in the tumor itself, none of the chromosomes looked that way. They were all homozygous.
Gotcha. Okay. So even when like the bands weren't like all the way on the peripheral, like
they were still, that still counts as homozygosity.
Gotcha. Okay, cool. Mm-hmm. And then I just had a question related to your research. I'm kind of curious, how you mentioned you did like a year of fellowship with a research grant, and that you're doing this clinical research, you published a paper. How much of your time do you spend doing like patient contact and care compared to clinical research, or even if you continue any basic research? I'm kind of curious about that.
Yeah, I will say it is really, really hard to be good at everything. I tried to do that, and it's hard to do like really good clinical care and really good basic research and find the time to write research grants and find the time to write papers and everything. So, I mean, there are people that do that. And I ended up running the thyroid program at Duke for a while. I went off to Wake Forest. I ran the thyroid program there for about 3.5 years. And then about 2 years ago, came down to Charleston, South Carolina, and I now run my own thyroid practice here, which is like all clinical care. So I was just telling him that I see about 300 patients a week right now. Yeah. With my nurse practitioners, it's crazy times. There's a lot of thyroid disease out there, lots and lots and lots, but lots of people to help, and lots of people who come in and they're like, oh my gosh, I feel completely back to normal. It's so rewarding to see that. But we're also doing clinical research still. So we just started a new clinical trial. We're looking at liquid thyroxine, so tyrosine solution, which is levothyroxine or Synthroid underneath the tongue. It's a liquid form of thyroid hormone. And in SIBO, or small intestinal bacterial overgrowth patients. So patients that have overgrowth of bacteria in the small intestine, that is where thyroid medicine is absorbed. And so we're doing breath tests and everything else. We just recruited our first 3 today, and we're doing that as well. Yeah, it's fun. It's fun. Research is so much fun. To actually like contribute new information to science is fun.
Awesome. Thank you.
You're welcome.
Let me ask you a question. In terms of the prevalence or incidence, I always forget which one. Are we seeing more thyroid disease now, or are we just better at finding it and screening for it?
We are so much seeing more.
Yeah.
And if you look at, there's like a really cool graph that I can't remember if I included it in the book that I wrote about Hashimoto's. I think I did, but it shows how like infectious disease, tuberculosis, polio, hepatitis has come down as we've gotten better at vaccination.
Yeah.
And then all the way up here are all of our other autoimmune diseases. Hashimoto's disease, Graves' disease, lupus, rheumatoid arthritis, all of these things. And we think that it is just the immune system being exposed to all of these crazy chemicals in our environment, chemicals in our food. We're all exposed to endocrine disruptors, all of these flame retardants. The flame retardants are even in children's pajamas. I mean, they're everywhere, and they bioaccumulate. So they actually, once you're exposed to them, you can't get rid of them. They accumulate in fat tissue, and then as you get older, you get more and more and more exposure. So we're making ourselves sick is pretty much the bottom line. And we're seeing more and more autoimmunity. Hashimoto's is just one of the more common conditions.
Yay.
Mm-hmm.
Yay, capitalism. Amy, unmute yourself. Hello.
Hi. So I just wanted to ask, I have actually a couple of questions. The first one is, do you see a lot of children in your practice? One, and then two, do you think it's more difficult to get funding as in the private sector versus like being in an academic setting? And then three, is there a way that people can, like you said, there's a lot of flame retardants in our clothes and things. Is there a way that people can see, kind of like how like food is like, oh, this is USDA organic or something? Like, can you buy like organic pajamas, I guess, basically, so that, you can try to reduce your exposure?
Yeah, that's a good question. I mean, so the first question, yes, I see kids in my practice down to about 8 years old. I usually recommend to women who have a huge family history of Hashimoto's disease, because it runs so commonly in families, that if there are nieces or kids or daughters in the family, to start checking them when they turn 10 years old for antibodies. Because if you can find Hashimoto's when they're young and you can get them on the right vitamins or teach them to wash their hands and not get sick, or get them on the right, nutrient course, you can actually decrease that autoimmune course, so that you don't wait until it kills thyroid tissue and they have to go on thyroid medicine for the rest of their life. Find it early and do something early. Wow. So that's number one. Second question about the funding. Funding is super hard in endocrinology in general, in thyroid disease too. I mean, it is like cutthroat. The easiest things to get funded if you're thinking about a research career are things in infectious disease and oncology. I mean, things that like the NIH puts a lot of money towards. So thyroid disease, not so much. There's not a lot of research funding in Hashimoto's disease, unfortunately, because there are so many people, millions and millions and millions of people in around the world with Hashimoto's. And as a clinician and now owning my own practice and seeing patients in clinical practice, you can do an investigator-sponsored study. So I can submit an idea to a corporation that has like a medicine, for example, and explain to them what I want to do, and they will give funding to clinicians like me to do that. So you have to explain what you're doing and everything, but it's not that hard to get it if you wanted to do clinical research. And then the third question was, what was the third question again?
Nope, you're muted.
If you can like identify clothes or objects that make you susceptible to these chemicals.
Yeah. So I would say my best advice on that, because there's a lot of kickback, against knowing those things, because so many companies use these chemicals in their products. EWG, it's called environmentalworkinggroup.org, does have a good amount of information on those things, but there's a lot of investigation you need to do into products to know that it is safe, that chemicals aren't added, flame retardants aren't added. That's probably the best place to go and look for like widespread information on it. But we live in a dirty world. We're all being exposed to these things every single day.
Don't tell that to the germaphobes. Thanks, Amy. Thomas, unmute yourself. Say hello.
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 Yeah. So I'm still stuck. Okay, first I'll say my question that's not related to the clinical case that you brought up. That question, it was actually mentioned in the chat like a while back, but in terms of endocrinology, do you also deal with areas other than the thyroid?
I used to. So when I was at Duke and when I was at Wake Forest, I did do diabetes and adrenal and pituitary and all of that. That's classical endocrinology. But when I started my own practice, I decided to stick to just thyroid. And I was told by many people that that would not work. They're wrong. Very, very wrong. So there's a huge need for people that actually understand thyroid disease and can actually dose thyroid medicine correctly. So we are busy. And so you can do whatever you want to do. It's just making sure that you know that you have the patient population and that you know what you're doing as far as treatment.
Yeah.
Okay. And I also got like another question. At one point, you were talking about like that heart tumor that was removed from that particular patient. And you're talking about like how the thoracic specialists, like thoracic surgery people, did that. So what sort of surgeries could you do as a thyroid endocrinologist?
So we don't do surgery. We just do minimally invasive kind of procedures, which is biopsy, alcohol ablation. There's a new procedure called radiofrequency ablation, which they use for like spinal tumors and liver tumors, but now it is being used for thyroid nodules as well. So that is, using positive and negative electrodes and heat to kill off thyroid tissue. So we do that as well in the office, but I don't do surgery, and endocrine in general doesn't. There is a subspecialty called endocrine surgery, which goes through the general surgery tract, and they are the ones that do a ton of the thyroid surgeries, the parathyroid surgeries, and the adrenal surgeries. Right.
And then like one last question that I had about the plan of treatment you had for the patient, like that case that was shown in the slideshows. Was there another way that another treatment path that you could have followed in order to avoid it getting rid of the thyroid, in order to avoid it that total thyroidectomy?
So, you could have done watchful waiting, but the tumors that were invading all of the different ribs and like the bony structures, theoretically, those were probably the ones with the second hit. So they were more aggressive. Instead of doing like external beam radiation, which you could do, but you'd have to do it in multiple different areas. Radioactive iodine is so much better tolerated. There's fewer side effects. You're killing these tumors from the inside out instead of having all of these additional side effects that you get with external beam radiation. That would probably be the only other option because you can't really remove them very easily with surgery. So I think that was probably the easiest option and the best option for the patient because she's she's cured right now. There's no additional disease. She is on thyroid medicine. She's doing well with that.
Thanks, Thomas. All right, Nick. Hello.
Oh, hello. Awesome talk, by the way. This is like a nerd's paradise. So you're doing an incredible job. You're really smart, and you also have great charisma. So I promise I'm not flirting with you. I'm just, by the way,
I thought you were talking to me.
Oh,
sorry. So as far as one thing that that's becoming common right now is personalized medicine. So looking at someone's genome and trying to mapping out their disease risk, for pretty much anything. A lot of third-party services, I know specifically one, Prometheus. What they'll do is they'll sequence your genome and they will run up all your single nucleotide polymorphisms and give you just a readout and and match those to PubMed and tell you what you might possibly be at risk for. Mm-hmm. Just generally, do you guys, I mean, just generally as a physician, is that something that you enjoy seeing a patient bringing in to you?
Absolutely.
You say that you need to be your best advocate, but I have actually gone to my own family physician with some of those paperworks in hand, and I felt like, they thought I was being a know-it-all.
Yeah, that is like a normal thing for people to do, and a lot of family physicians and internal medicine doctors will be like, whatever, because they are not used to looking at that. But to me, I love looking at that stuff. I think it's so neat. That is the way medicine is going. It should be personalized. The genetic interpretation is really important. It's not the only thing that's important, but it's part of the puzzle. So in my practice, we don't just look at the thyroid numbers and put people on thyroid medicine. We will look at other things. We talk about nutrition. We talk about vitamins. I will take their genetic information like from 23andMe, like ancestry, health and ancestry, and I'll plug it into like this algorithm to figure out, do they have issues with estrogen metabolism? Do they have issues with vitamin D or B12 or folate? So important for me to help them like with their vitamin regimen and what they should be looking for with their nutrition. And people feel so much better when that's all optimized for them. It is a personalized approach to medicine. Don't ever let any other doctors like poo-poo that stuff. They're just doing that because they don't know what you're giving them, and they don't want to look like an idiot when you give it to them. That's why. So awesome. Any physician who's smart should be open-minded about anything you give them.
Great. Thank you for the answer.
I concur. Thanks, Nick. All right, last question. Natalie, unmute yourself. Hello.
Hello, can you hear me?
Yep.
Yes.
Great. Well, thank you so much for the presentation. I have heard that, especially with thyroid issues, people can experience symptoms for many years, and it can take them a very long time to identify that the causal issue is with the thyroid. Mm-hmm. So I was wondering what the implications are for the kinds of clinical presentation that you see and what you think can be done for earlier detection and diagnosis.
Good question. Very good question. So about the thought is about 5 to 7 years is needed for actual diagnosis. And that is because, and like what I said with like screening kids when they turn 10 years old, the immune system is what starts first. The immune system starts to attack the thyroid first. And that attack causes the thyroid not to work optimally, but it can also cause destructive thyroiditis, which is where the the immune system kills thyroid cells, and those thyroid cells have stored thyroid hormone. They will release thyroid hormone, T4 and T3, in a process called destructive thyroiditis. So your TSH can look perfectly normal for years before you actually get a diagnosis, before you've destroyed enough thyroid tissue where the TSH actually can elevate. In young adults and in teenagers, this presents mostly as anxiety and depression and weight changes, either up or down, but mostly anxiety, depression, and panic attacks. And so those are all neurotransmitters, but they are very much impacted by the release of thyroid hormone in autoimmunity. So my thought is you should be screening people for the autoimmune antibodies, TPO, thyroglobulin, TSI, TRAbs, before you actually even look at their thyroid levels, because they can look normal for a long time.
That's really interesting. Thank you so much.
You're welcome.
Very cool. Thanks, Natalie.
Mm-hmm.
Well, Dr. Brittany Henderson, thank you so much for taking some time tonight to educate the youngins out there about thyroid disease and disorders and everything that you do as a thyroid specialist. So thank you so much for your time.
Yeah, guys, thanks a lot. We had fun.
All right. Have a wonderful night, everyone.
Thank you.
Dr. Henderson, thank you so much. Have a great night.
All right. I'll talk to you soon. Bye-bye.